I did my case study on progressive supranuclear palsy, which is a form of Parkinson's. They don't know much about this disease yet, but they're doing further research, and I want to share with you what I learned from my clinical rotation and working with this patient. So the chief complaint for this patient was repeated falls related to PSP. PT diagnosis was lack of coordination and repeated falls. Description of PSP, so it's a form of Parkinson's. It's linked to a pathological accumulation of a protein called T in certain areas of the brain. The normal function of this protein is like a skeleton on the nerve cell to protect it. In PSP, this protein forms into clumps and is thought to damage nerve cells, nerve endings in the brainstem, basal ganglia, and cerebral cortex areas of the brain. These are areas that control balance, thought processes, eye movement, speech, and ability to swallow. So with these patients, you're going to see excessive drooling, things like that. His past medical history, so he has PSP, supraventricular tachycardia, gait disturbance, falls, and expressive dysphagia. His range of motion, so his active range of motion for bilateral lower extremity is within functional limits. His manual muscle test for bilateral lower extremity is 4+, and coordination for bilateral lower extremity is fair, and his posture and standing is fair+. Now, with his gait, during his eval, he wasn't able to maneuver a rolling walker due to lack of coordination. So the PT wanted to see how he did without any assistive device, and he was only able to take 3 steps with mod plus assist. With his gait, he demonstrated inability to safely and effectively utilize the rolling walker. He had decreased coordination in his lower extremities, so he had difficulty with foot placement. He demonstrated loss of balance. He had trunk sway, which all these things, is affecting his gait overall. He had decreased safety and independence with the directional change. He was unable to maneuver around objects safely. And he had a scissoring gait, which caused instability with his gait. As far as balance goes, standing dynamic balance was fair-, sitting dynamic balance, fair+, sitting static balance was good-, standing static balance was fair. With transfers from bed to chair, he required min plus assist and required min plus assist for sit to stands as well. With his transfers, he demonstrated improper hand placement, reaching up or pushing up from his wheelchair, then grabbing onto his walker. He didn't reach back safely. He didn't lower himself down. He just kind of flopped, which could lead to compression fractures. He had insufficient balance, impacting his safe transfers. Short-term goals, so patient will demonstrate an increase in safety awareness to fair to impact transfers. Patient's static standing balance will be improved to fair+ to impact transfers. Patient will demonstrate an increase in dynamic standing balance to fair to impact standing. Patient will perform transfers from bed to chair with contact guard assist. Long-term goals, patient will demonstrate an increase in safety awareness to fair+ to impact transfers. Patient's static standing balance will be improved to good- to impact transfers. Patient will demonstrate an increase in dynamic standing balance to fair+ to impact transfers, and patient will perform transfers from bed to chair with standby assist for his long-term goals. Treatment plan, so we did neuro re-education, self-care, ADLs, TheraAct, TheraX, wheelchair management, gait training, and group treatment. The frequency and duration of this was 5 days a week for 60 days. Use of assistive devices, he was able to independently maneuver his power chair. In therapy, we utilized a rolling walker and a pair of little bars. So tests performed. Most of these tests were done because of recent falls that he had. So he had a cervical spine CT which showed no fracture, just degenerative change with no acute findings. He had a right elbow x-ray, which presented with no fracture, a venous ultrasound, which showed no signs of DVT, an arterial ultrasound, they found no stenosis present. He was on 3 different types of medications for PSP. One of them was carbidopa, which helps decrease Parkinson's symptoms such as rigidity and akinesia. Side effects of this medication include dizziness, headaches, lightheadedness, nausea, vomiting, trouble sleeping, loss of appetite, unusual dreams, and it could cause the saliva, sweat, and urine to turn a dark color. Another medication was Nuplazid, which is used to decrease hallucinations and delusions associated with PSP and other mental and mood disorders. Side effects of this medication include swelling of the ankles, hands, and feet, along with confusion and nausea. The third medication was cyclobenzaphrine, which is used short-term for muscle spasms and to increase relaxation of muscles. Side effects of this was drowsiness, constipation, dry mouth, dizziness, and fatigue. Student involvement, I was fully involved with the treatment for this patient. We focused on transfers from wheelchair to bed and sit to stands. We really had to focus on his safety awareness because he tended to be impulsive and wanted to rush. So we took it slow, did it step by step, and did it properly to increase his safety awareness. We did static and dynamic standing balance activities. We did wheelchair mobility, coordination activities, and we were able to do a little bit of gait training in the parallel bars. And I also provided lower extremity strengthening to this patient to improve his transfers and his ambulation. The result of therapy, so he presented with an increased strength in his bilateral lower extremity, along with an increase in static and dynamic standing balance. Patient still had difficulty pivoting during transfers, picking his feet up. Patient tended to be lethargic, so I felt like that hindered his progress in therapy, and that was one of the side effects of cyclobenzaphrine. So I feel like if he wasn't on that medication, then he could have progressed more in therapy. Discharge plans, so I was at a SNF. This patient is a long-term patient. So he was discharged to restorative care, which is where nursing will come in and do range of motion and simple exercises to maintain his strength. But he will not be discharged to another facility since he is long-term. Patient education, again, we had to really focus on his safety awareness with transfers, in-room mobility. So we went over every day the same thing, him reaching back for his wheelchair or him pushing up from his wheelchair, lowering himself down to prevent compression fractures. We educated him on staying within his basic support when reaching for objects on his table in his room. We did pressure relief education with him in his bed and in his wheelchair. And we also went over his education of not getting up and doing things on his own that's not safe. So hitting his call button and waiting for assistance instead of, rushing everything and feeling like he needs to do it all by himself. We also did posture education, so having him stand up tall, look at something straight ahead, pulling his shoulders back. Appropriateness or inappropriateness of treatment. I feel like overall, everything was appropriate for this patient, such as working with safety awareness, coordination, balance. The only thing that I feel like we needed to do more of was gait training. Now, this wasn't one of his goals, so it wasn't worked on very much, but I feel like this patient would have benefited more if we focused our time more on that. And I feel like it probably should have been a long-term goal, and if the patient wasn't able to do it, then it could have been discharged. So I feel like the patient should have just had that opportunity to try. What I learned medically, so I learned about PSP in general because I didn't know what this was. I learned it was a form of Parkinson's, but just a little bit more advanced. I learned that it was from accumulation of a protein causing basal ganglia dysfunction. Another name for it was Still-Richardson-Olszewski. I learned new static and dynamic standing balance activities, such as, just standing up and doing a fun puzzle that they enjoyed, or heading a balloon back and forth and standing, having them reach outside their base of support to do so. I learned different transfer techniques. So with a patient with PSP, you have to learn to let the patient do the majority of the work, and you just help the rest of the way that they can't do. So that way they can work to being independent, and also just taking a step back, slowing down, and letting the patient try to ultimately progress in therapy. I also learned different lower extremity coordination techniques. So just kicking a ball back and forth or rolling a small ball around in a circle all helps with coordination of the lower extremities. And I also learned, most importantly, how medications can affect a patient in therapy. So like I said, this patient was lethargic. I couldn't keep him awake during therapy, couldn't keep him on task. So I felt like I learned better, what time of day I needed to get him in order for him to, have that medication and be able to participate optimally in therapy. So I hope what I learned, I was able to inform you guys in case y'all had a patient like this in the future. Since there isn't a lot of research on it, this is what I worked on with this patient. So I hoped this helped you guys out in the future.